Good morning or good afternoon, depending where you're located, everyone. And welcome to our webinar focusing on approved and investigational treatments for AL amyloidosis. All our previous webinars can be viewed on the webinar section of our website, amyloidosissupport.org, and on our YouTube channel. This webinar should be available and up there in a week or two. You won't have access to this webinar for another week or so. In the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi, everybody.
A voice out of the dark there. And our Special Projects Director, Bob Gibson. Paula will join us later to talk about financial aid, and Bob will be sharing updates on our patient registry. I, of course, am Muriel Finkel. If you type in questions in the Q&A section, please make them as short and general as possible. Not too much personal information, as this recording will be public very soon. If we don't have time for all your questions that are typed in, we'll ask our panelists to answer them in writing, and we'll share the responses with all of you later on in a week or two. The chat portion has been disabled, but there will be occasional useful items popping up there posted by Paula. Our esteemed panelists today include Dr. Angela Dispenzieri from the Mayo Clinic in Rochester, Minnesota, Dr. Michaela Liedtke from Stanford, Dr. Nelson Leung from the Mayo Clinic in Rochester, Minnesota, and Monica Fawzy Bryant from Triage Health. I do want to remind everyone about 3 upcoming in-person meetings that we'll be hosting. These are not virtual meetings. We have one in Cincinnati coming up on September 19th, Boston meeting on October 3rd, and the Chicago meeting on October 17th. Details of these meetings and all our meetings can be seen on our website, amyloidosissupport.org, or email me at muriel@amyloidosissupport.org. If you have any questions about today's event during the event that aren't clear or you'd like more information, email muriel@amyloidosissupport.org, and I'll make sure we forward it to the right person so you get answers. We're going to be working off our AL amyloidosis chart today, and Paula's going to be putting a link to that in the chat. So that way you don't have to worry about how do I spell whatever it is that Dr. Leidtke or Dr. Dispenzieri is referencing. Everything will be right there on the chart. Okay, there's going to be a brief survey when the meeting is over, okay? And we ask that everyone fill it out. It's really important that you do this because this is how we decide how to do our future webinars. And if you have to leave early for any reason, you will have an option to fill it out at that time as well. Quick reminder, we do have a private group on Facebook for our AL amyloidosis patients. So if you're not a member, again, email me, Muriel@amyloidosissupport.org, and I can give you information about joining that. Paula might put a link to that up in the chat as well. Okay, we're going to start now with the standard of care, venetoclax, stem cell transplants, some of our old-time stuff, and take it away, Dr. Angela Dispenzieri.
All right, so hello everybody, and I'm going to get my slideshow going here. Okay, so again, we're going to do some basics for those of you that have been around with amyloid for a long time. It might feel a little too basic, but in the question and answer, hopefully we can catch up and meet everybody's needs. We have 15 minutes to sort of touch on this topic, so we're going to advance as we go. So just a little primer. My lovely little cartoon is, this is a person, and in their bone marrow, there are these cells called plasma cells, and they make these immunoglobulins that normal people make immunoglobulins without disease and so on. But in patients with AL, there's too many plasma cells, too many immunoglobulins, and especially these free light chains. And those free light chains can then form these amyloid fibrils that deposit in the body. And so this is kind of the disease, and this is how we have to approach it and attack. So the goals of therapy, really, the first thing is to kill those plasma cells in the bone marrow. Because when we do that, what happens is we have fewer of those light chains, and we have the ability of the body sort of not making more amyloid to hurt the organs, and we also are allowed or able to get healing. So here is the bone marrow plasma cells, the free light chains. We can follow a patient as they go month by month or even week by week to see if our chemotherapy is killing these circulating free light chains. And then we call that hematologic response. And then over time, it takes much longer to get the organs to improve. And obviously, that's what's most important to everybody, right? If you have shortness of breath because your heart is involved, or you have fluid retention because your heart's involved or your kidneys are involved, that's what you want to feel better. And that does take more time than the other. Now, the drugs that we use to, and this is sort of a variant of what Muriel is sharing, and I guess I don't have the tri-specific on here, but anyway, but we have all these different classes of drugs, and then each of these are the separate drugs that can be included. And this is these are our tools to help. Now, the only thing that's ever been approved for amyloid is really the Daracibor-D so far. But these are drugs that have been used in multiple myeloma, which is a cousin to amyloid, the ones in black, and those are approved in that space. The red ones are still in clinical trials and so on for even multiple myeloma. A word about there are some fibril-directed agents, pertamimab and anselamimab. These are actually drugs or antibodies that are trying to help suck the amyloid from the tissues faster. The pertamimab is sort of not being developed anymore because it didn't show success. The anselamimab may be useful in patients with kappa amyloid, so more clinical trials are ongoing. But you might say, well, yeah, you need to suck the amyloid out of the tissues, right? Like you're killing plasma cells. How is that sucking the amyloid out of the tissues? How am I ever going to get better? And so the analogy I like to use is if you imagine that you have 100 guys laying a brick wall, and they're just laying these bricks, and this, imagine, is like the amyloid. And your body knows the amyloid is wrong. And so your body is going to try to take brick by brick, try to dissolve that amyloid. But it's like one against many too many. So our chemotherapy, what it does is it basically gets rid of the guys that are laying the amyloid. And then your body will heal itself over time. And so that's where we can kill plasma cells, drop those light chains, and organs can eventually improve. Okay, so therapy. So this is the only, quote, FDA-approved regimen for AL amyloid, and it's approved for patients' first-line treatment. And it basically is combining cyclophosphamide, which is the Cy, the B is for bortezomib or Velcade, and the D is for dexamethasone. So what this trial did is compare these three drugs to those same three drugs, but with daratumumab included. And this was a really important trial because, as I'll show you in a moment, adding in that daratumumab as part of the therapy has made a huge difference in terms of the numbers of patients that respond, as well as the depth of response that patients achieve. And that translates into better survival and so on. And so, again, this is the designs, basically roughly 6 months of just the 3 drugs versus 6 months of the 4 drugs, followed by then just maintenance with the daratumumab. And what was found, so if we focus on the left-hand side of the slide, the orange is just the 3 drugs, and the purple is the 4 drugs. And what you can see is that the deepest purple is what we call a complete hematologic response. That's like the deepest response you can get based on the blood work. And you can see it was like 59% versus 19%. So almost 3 times better, the deepest responses. And if you look at, we also like to look at something called very good partial response in the hematology response world, and that's 79 versus 50. So much, much better. And then if we look at heart responses. So we measure cardiac biomarkers and things like that to say how is the heart improving. And at 12 months, again, 57% versus 28%. And the same thing here's kidney, 57% versus 27%. So the 4 drugs really are so much better. And that's why the DARA CyBOR-D or DARA VCD is our standard treatment. And then this is sort of what we call a Kaplan-Meier survival curve, but basically what it's showing is that, at time 0, everybody is alive, but as time goes on, and quote, progression free, like they're not, quote, getting worse at the very moment. But as time goes on, people's disease may, relapse or not be responding, or unfortunately, some people do die. And that's what we call this progression free. So at 5 years, the number of people who are alive and not needing to change therapy is 60% using that DARA VCD versus 33% without the DARA. And even the survival, so 5-year survival, over 3/4 of patients are alive who use the DARA VCD. And so that is really why it's such effective therapy. Oh, I neglected to mention, Muriel had said that people are always asking, do you really have to do this whole, 18 more months of daratumumab? The answer is, this is the way the trial was done. So some people play it by the book. This is how we got those wonderful results. So I'm going to do it exactly that way. Others are saying, that there's some institutions where they just sort of cut it just to see, and they'll see how patients do, because more than likely going for another 18 months is not necessary. But there are ongoing clinical trials studying how long do you really need to do this? Can you shorten the duration of the daratumumab? This is a very busy slide, but I just want to, when we have newly diagnosed patients, the most important thing is, how is the heart? Is the heart very sick, or is it not very sick? And if it is very sick, we still are using the DARA VCD, but we'll often reduce doses and, go a little bit more gently. Some people may exclude one of the drugs or whatever. But essentially everybody is getting the DARA VCD these days as standard therapy. And then we look after a couple of months and we say, are we getting benefit from a heme standpoint? Like, have we gotten rid of those guys laying down the amyloid? And if the answer is we've really gotten rid of most of them, then we'll kind of carry on as we are. But if we're not happy that we've gotten enough of a response, then we're going to be looking at changing therapies. And you're going to hear a lot about BCMA-directed therapies by Dr. Liedtke later, these CAR-Ts and bispecific T-cell engagers. I'm going to tell you a little bit about venetoclax. But the one thing you might notice, transplant, stem cell transplant, was something that we used tons of earlier in yesteryear. But with this DARA VCD, so many patients are getting such deep responses that the number of transplants that we're doing has really markedly reduced. And again, here is, data with stem cell transplant. Patients who get the deepest response, their survival is more than 15 years. It's probably like just a normal survival for your average person that's the same age kind of thing, really can do very well. But not everybody, people can relapse and unfortunately pass away. Patients who get less deep responses also can do quite well. Again, 50% are alive at 10 years, and these are old data, not accounting for all the new therapies that we have. And this is just another similar kind of thing. If you get a deep response after a transplant, yes, you have long remission, but the thing we're learning is that if you're getting a deep response with, for example, the DARA CyBOR-D, you are potentially going to do as well as this. So I can't say we have 15-year follow-up, so more to follow. And we do, for patients who are not getting deep responses, we may consolidate with stem cell transplant. Options for relapse disease or refractory amyloid. Again, this same list, we have this whole menu of things that we can mix and match and use depending on how the patient is doing, how frail they are, what they've already had. All these things go into the calculus of doing things. But we're going to talk about a drug called venetoclax, which is a pill that has been around for, boy, I don't know, probably 15 years, maybe 20, I don't even know. But it's been around. It was used in chronic lymphocytic leukemia. But it was found that patients who have in their plasma cells what we call translocation 1114, which is just in those plasma cells, the amyloid light chain making cells, this sort of a switch, reattachment of chromosome 11 and 14, those patients will respond very nicely to this venetoclax medicine. And it so happens that about 50% of patients with AL amyloid will have that translocation. And so this is a nice medicine that we can sort of throw into the mix. Now, there's really not published formal clinical trials, but a lot of retrospective data where, people have tried it on patients and seen, gee, this looks really good, and then they report it and we talk about it. There are ongoing trials to really get a better handle on the side effects and all the rest. But the long and the short, this is kind of a summary of what we see. About 48% of patients will get a complete hematologic response using venetoclax. So nearly half. Some studies say a little lower, some studies say a little higher, but what we call this very good partial response, also we're getting close to 75%. And the durability of that seems to be in the order of 2 to 3 years on average. Again, differences. Some people will use it as a single agent, some will combine it with other drugs, but even as just venetoclax as a single agent, it can be highly effective. I just wanted to throw this in. This is a patient, and just to sort of remind you of the journey of how the disease can go. So on the y-axis, sort of the up and down, this is the kappa-free light chain. And when the patient started, we don't have it in our system because they were started their therapy elsewhere, but they started around 17, right here where I'm moving my cursor, and they got some therapy. They had some Revlimid and Dex VRD because they thought they had myeloma, not amyloid. And it did go down, but we consolidated this individual with a transplant. And it went, this blue area is the normal range. And so it went into the normal range and they did well for, like 3 years or so. And then the numbers started going up and they got some other drugs. And that didn't really do much. They got the drug here, but the number went up. So actually had a second transplant because back in the day, we had many fewer alternatives. Now we have more alternatives. Went into remission, but it only lasted for, like 2 years. Tried DARA, this person, it didn't seem to work very well, but then we used venetoclax and it came down. We did it for about 6 months and was doing okay, but it started to come up. So we said, yeah, let's do it again. And this patient's been on it for about 4 years. And so again, sort of how patients, even when the disease sort of starts coming back, patients can still do well. Just a friendly reminder, these are a bunch of different medicines, and this is a slide I show to my, colleagues that are physicians, but I think it's important for patients to realize as well. Each of these medicines that we use have side effects, and so this like heart toxicity is a little, heart with a thunderbolt going through it or a lightning bolt going through it. They can hurt the heart. And so it's always important to be thinking about, or can bother the muscles or the blood and the bone marrow, or cause fluid retention and so on. So the important thing is don't always assume if you're feeling worse that it is your disease getting worse. Sometimes it's our medications, and your doctor has to be very, very mindful about okay, wait, do we hold the medicine and see if the drug is making this individual feel worse? So with that, I'm just going to conclude. The first line is DARA VCD, and the vast majority of patients do exceptionally well with that. And that means we're doing fewer stem cell transplants, but we still do some. We typically post-transplant don't use maintenance unless the patient has a lot of myeloma-like features. We strive for what's called a very good hematologic response or better. Some people say I need to have a CR, and the more drugs we have, the greedier we get and the better, the deeper we want, but we have to balance, not beating a patient to smithereens to just get a better number. As long as they're doing well with the VGPR and the organs are getting better, we can be happy with that too. The venetoclax is really very promising, and you're going to hear wonderful information about bispecific T-cell engagers and CAR-T, because I think that this is really the next frontier being studied in clinical trials, but there's some retrospective data, and there's just so much reason for optimism. And with that, I thank you for your attention.
Thank you. Thank you. That was really great. And we have lots of questions, which we're going to save for the end. So, but we really appreciate that very thorough explanation. And now we're going to go on with CAR-T, bispecifics, and depleters, all the new kids on the block, which I guess aren't so old, new anymore. Okay, with Dr. Michaela Liedtke. So, Dr. Liedtke, take it away.
Yeah, thank you so much. I'm so excited to join you all today and talk about CAR T-cell therapy, bispecific antibodies, and amyloid depleters all in 10 minutes. So to put those different therapies into perspective, I listed here the targets and the goals of treatment. So on the left side, you see that the CAR T cells and the bispecifics, they target the plasma cells that Dr. Dispenzieri was talking about, the plasma cells that produce light chains that are toxic and deposit in organs as amyloid. And we generally now use CAR-T and bispecifics when the standard treatment like DRSI-4D or the other therapies like venetoclax are not working and not effective anymore. And essentially the goal there is to prevent new amyloid from depositing. In contrast, on the right side, the depleters, they target the amyloid deposits themselves. And we use them in conjunction with standard treatment, with standard chemotherapy treatment. And here really the goal is to degrade the existing amyloid deposits. So let's first start talking about the CAR-T and bispecifics and remind ourselves about T cells. So these therapies employ T cells, but what are T cells? So T cells are immune cells that help protect your body. They're essentially responsible for finding and getting rid of anything that doesn't belong, like infections or cancer cells. But in blood disorders like amyloidosis, the T cells don't work properly, and they may just not recognize or be able to attack the harmful plasma cells. But that can be addressed with these newer treatments that we want to talk about. So CAR T cells are cells that are manipulated to express a chimeric antigen receptor, that's what the CAR stands for, on their surface. And that receptor makes it easier for the CAR T cells to find the abnormal plasma cells and destroy them. On the other hand, bispecific antibodies, those antibodies have two arms. And so with one arm, they reach out to the T cell. And with the other arm, they reach out to the cell that they want to destroy. And so they bring those two cells in close proximity so that the T cell is able to destroy the abnormal plasma cell. And so really the two treatment approaches, the CAR-T therapy and the bispecific antibodies, have a common goal, which is to activate T cells to destroy amyloid-producing plasma cells. But the CAR-T cells, they have to be collected, from an individual, and they have to be sent away to a company to be manufactured. It's personalized treatment. These are your own cells that you get back. And the big advantage is that it's just a one-time infusion. On the other hand, the bispecific antibodies, the T cells remain unchanged, but it's an off-the-shelf treatment, so it's readily available. But at the same time, you have to give it repeatedly because that bispecific antibody doesn't, last forever. Because both treatment approaches, the CAR T cell therapy and the bispecific antibodies, both activate T cells, their toxicities are actually also quite similar. And there are three that I wanted to highlight. One is cytokine release syndrome, or CRS for short. That comes along with fever, low blood pressure, low oxygen. The other is a neurological side effect. We call it immune effector cell neurotoxicity, or ICANS. That could manifest itself by having trouble finding words, or being confused, or having a tremor so that your handwriting is off. And then the other main thing to look out for and be careful about is infections. So in the next couple of slides, I just want to go over a few examples. So for CAR-T, there's Nexicart, which is the only CAR-T that's been in clinical trials for amyloidosis. And they started off with the phase 1 study where they actually only treated 10 patients, but they found this to be very effective and also not very toxic. And so they went on to do a phase 2 study, and that study recently completed enrollment. And so let's look at the results of that study. So this was reported on the first 23 patients who were enrolled. And what they were able to show is that there's really rapid normalization of those pathologic light chains. So each line is an individual patient, and the numbers go down like, by 100%, so essentially to normal in almost everybody. So 96% of patients, the disease markers normalized, and very, very quickly. In this little box, you see that for some patients, it was as early as 7 days, like just a week. And luckily, CRS, it was seen in about 3/4 of patients, but it didn't last very long and it was not very severe. And fortunately, there was no neurologic toxicity. This is just another way of looking at the light chain data. I don't know if you can see my cursor, but this shows how quickly the light chains go down. And then, just like Dr. Dispenzieri explained, we also want to look at, organ responses. Is there actually improvement of the heart and improvements of the kidneys? And what they showed is that organ responses at that initial time point was seen in 2/3 of patients with heart disease, about the same number of patients with kidney disease, and everyone with liver disease responded. And the median time to response was just about a month for the heart and just about 3 months for the kidneys. And as we follow those patients on the trials, I think that the response rates for organ responses will actually only get better. This is an example of a bispecific antibody, teclistamab. This was not a clinical trial, but it was a great effort of multiple different countries to put together a cohort of patients retrospectively who had been treated with teclistamab. And you see there's only one patient who did not respond. That's this patient here in red, but everybody else had a response, and those responses are quite long-lasting. This is a clinical trial. It was a relatively small cohort of, I believe, 9 patients. And I really like that example here on the left, where this is one individual patient who starts off with DRS-IBOD, which is very effective therapy, and the light chains go actually down quite nicely, but then it kind of reaches a plateau. And then they ended up actually going up higher when the treatment was changed to pomalidomide. And here is when elranatamab was given, and the light chains just plummet, like, within a week. And the overall response rate in this particular study was 100%. So essentially every patient responded. And importantly, no new adverse events were noted in patients with amyloidosis. You could have worried that if somebody has severe heart disease, would that potentially be dangerous? When patients did develop CRS, 6 out of 9 patients had cytokine release syndrome. But for the most part, the patients actually handled it really well because the CRS is relatively mild. This is just, to me, a very, very encouraging slide because it shows all the ongoing trials with bispecific antibodies. So there's teclistamab here on the top. There's an ongoing study. This is the elranatamab study that we talked about, but there are other BCMA targeting bispecifics that are also being looked at in clinical trials. So we will learn much more about how these drugs work and who benefits from them. And lastly, I want to talk about amyloid depleting antibodies. So enzalutamab is an antibody that binds to toxic amyloid fibrils and induces their phagocytic removal. So to stay with Dr. Dispenzieri's analogy, you don't just get rid of the bricklayers, but you actually sort of target the amyloid fibrils for faster degradation by the body's own immune system. And this was shown to work in an animal model where the animals who had either lambda or kappa amyloidomas were given enzalutamab, and these amyloidomas were eliminated. But of note, the kappa amyloidomas were actually, they resolved faster than the lambda ones. And this is going to be important when we look at the clinical data. Initially, there was a phase 1 study done that gave only enzalutamide that proved that it was well tolerated. And then there was a phase 2 study done that showed that it was well tolerated when it's given in combination with standard chemotherapy with either Cyborg-D or Cyborg-D. This is the design of the clinical trial of enzalutamide. It was a huge effort. It's a multi-center study with a lot of international participation, which is really wonderful and sets up, I think, the amyloid community for other trials like this in the future. There was a lot of really great collaboration. It's double-blinded, so that means that neither the patient nor the treating team knew who was getting the drug or who was getting the placebo, and it was randomized and placebo-controlled. So all patients, and these were patients with treatment-naive, newly diagnosed advanced cardiac amyloid, received appropriate first-line treatment for their plasma cell dyscrasia. So in other words, Cyborg-D or Cyborg-D, depending on which country they were in. And then they were randomly assigned 1 to 2 to either receive a placebo or receive the drug over multiple months. And so the trial looked at something that's called all-cause mortality. And so what you see here on the right side are patients with lambda subtype amyloid. And the blue line are the patients who received the enzalutamide, and the red line is the placebo group. And there's essentially no difference. So patients lived around the same time frame, no matter whether they got the drug or the placebo. But importantly, on the left side, you see that in patients with kappa subtype amyloid, the patients who received enzalutamide did a lot better. So in that particular population, enzalutamide shifted the survival curve and reduced all-cause mortality by 62%. Of course, that's really exciting for patients with kappa subtype, but it's really disappointing for patients with lambda subtype. And we think that it has to do with the fact that the antibody was initially raised against a kappa subtype amyloid. It was shown to bind to lambda, and in the animal model, it cleared the lambda amyloidomas as well as the kappa ones, but in people, it just doesn't work well in lambda amyloid. But this is sort of hot off the press and was just published, I think, a week or two ago. This is work from Dr. Lench's group from Columbia, where they've been able to develop a lambda-directed antibody. This antibody is called 1F10. And if you look at the bottom, this shows the ability of that antibody to bind. And so the 1F10 is the lambda antibody that binds to lambda renal amyloid really well. And in comparison, 111F4, that's the old name for enzalutamide. And so you'll see that also did bind to the lambda amyloid, just not nearly as well. So we're really hopeful that with this other antibody that we can offer eventually the same kind of therapy to patients with lambda subtype amyloid as well. And in addition, there is another drug that's called PROT-001 for amyloidosis. This is not a depleter, and it also does not target the plasma cells, but it's a light chain stabilizer. So it's a small molecule that's available actually in an oral form. It's called a pharmacological chaperone. It binds and stabilizes the light chain protein in the blood and prevents it from misfolding. So this could potentially be another approach that's complementary. So if the chemotherapy destroys the plasma cells that produce the amyloid fibrils or the light chains, and this chaperone protein can stabilize it and prevent it from depositing, and then we can have depleters that actually take the amyloid out of the organ. I think that would be like a really elegant three-pronged approach to really control amyloid from all different angles. So to conclude, both CAR T and bispecific antibodies activate T cells, and they're very efficacious. Side effects include CRS, ICANS, and infections. CAR T takes time to generate, but the advantage is that it's a one-time treatment. Bispecifics, you have to take the treatment on a more ongoing basis, but the advantage is that it can be taken off the shelf, so it's available to everyone. Anselamimab is a first-in-class kappa-directed fibril-depleting antibody that reduces mortality in patients with AL of kappa subtype. But for patients with lambda disease, there are lambda-directed fibril strategies in development and also stabilizers. Thank you so much for your attention.
Thank you. That was really, you had some exciting new news there. That we appreciate that. And there'll be lots of Q&A for you in a little bit as well. Before we get to Dr. Leung, I'm going to be talking to everyone's favorite patient advocate for, everyone's favorite legal patient advocate. Okay. Monica Fawzy Bryant from Triage Triage Cancer. Hello there and good morning.
Hello, thank you so much for having me.
Oh, we love having you. You know that. And I just have a couple of questions for you, okay? And I asked this last week, and we got an amazing response. So people really want to know what makes lawyers and want to start a nonprofit to advocate for patients. So let's ask you that again.
Well, we really saw that there was a gap in the healthcare community of education around the legal and practical issues that so many people have to navigate after a serious medical diagnosis. So we've heard about all this incredible science, but if people don't have the right health insurance policies so that they can access the new medications, the science means less. If people don't understand how to take time off work or replace lost income to access that treatment, then it means less. And so really, we are trying to fill that gap so that people have the information they need and they can make the right decisions for them.
Great. And when I first met you several years back, you were Triage Cancer, but you were doing all these wonderful things and working webinars with us and our people. It was great. But our people were kind of uncomfortable with the name cancer because, they don't consider amyloidosis a cancer. Okay. And now you have Triage Health, which makes our people feel a lot better. But what is the difference between Triage Cancer and Triage Health?
Well, I really appreciate that feedback. And I think as I shared last weekend, you were really one of the people that pushed us to create the program for Triage Health because of that feedback. So the organization, the nonprofit, is still named Triage Cancer. But Triage Health is a program of the organization where we're providing all of the same education, materials, events, resources for free to anybody who needs them, regardless of the diagnosis that they are dealing with.
That is great because our amyloidosis patients, they're an older group. Okay. And so they have issues about life on the job, Social Security disability, Medicare, Medicaid, caregivers, life insurance, health insurance. What can Triage Health offer them?
So those are all the topics that we talk to people about. And so we host educational events ourselves that people are welcome to join. We do monthly webinars. We have a longer conference coming up in November. All of those are online and all you have to do is register to attend. We also have printed materials and animated videos and a podcast. And so we try really hard to provide the education in a variety of formats because we know people learn in different ways. And we also know that people sometimes have different capacities, right? If someone's newly diagnosed, they might be feeling really overwhelmed by all the science and medical information they have to now navigate. And maybe the legal piece is just one step too far. And so I would suggest, watch a 5-minute animated video. Someone may be further down the path and maybe they're transitioning into Medicare and they want all the details so that they can make the right choices. Then I would say, come to one of our Medicare events because you'll get all the details. But then in addition to the events and the materials and the resources, we also have an opportunity for people to get one-on-one help. So there is a form on our website at triagehealth.org/get help. And if people fill out the form, let us know what their questions are, they'll get a link in their email to schedule a call with one of our staff attorneys. And on that call, we don't represent people, we can't fill out forms for people, but really what our goal is to give people the information about the different possibilities And then the pros and cons of those different options. What, for example, does it mean to someone if they choose a Medicare Advantage plan versus original Medicare? What are the ramifications of that? And then we let people with that now information go and make the right choices for them.
So if they go to triagehealth.org/get help, they'll get one-on-one individual help from one of your great people there.
Correct. So they just fill out the form, check your email for a link to schedule the call at a time that's convenient for you. And we call you at that time and we have about a 30-minute conversation.
At no charge.
No charge.
I love it. I love it. Okay. So I know there's a lot of changes coming up to health insurance this year. So what are you doing that can help our patients?
There are some really large changes coming to all forms of health insurance. So Medicaid, Medicare, Marketplace. There may even be some changes to employer-sponsored insurance, and it's all sort of happening at once. We are hosting a webinar on October 1st for anyone who would like to come and learn more about these changes. I will tell you that not all of them are going to be set in stone because we're still waiting for court cases to be decided and additional regulations, but at least in October, we'll be able to share what we do know prior to open enrollment for 2027. Again, anybody is welcome. All you have to do is sign up on our website.
That's very, very great. So if anyone has any questions, you know, they were listening to you and they were just so excited to hear all this. If you have any questions, email me. And I'll make sure you get all the information that Monica just said. And also you'll be able to watch this video in another week or two as well. And so if, you know, it takes me 3 times to learn something. I have to hear something 3 times. I don't know if that's an average learning curve or whatever. So if I want to rewatch something of yours, do you have webinars that I can rewatch?
We do. So we record all of our monthly webinars and they're archived on our website. So you go to the website, they're broken up by category. So what do you want to learn about? For example, there's a Medicare category, and then it's all the resources that we have related to that topic under our resources by topics page.
That's wonderful. Thank you so much for joining us today. And if anyone has any questions for Monica, type them in and she'll be happy to answer them.
Sounds great. Thank you again so much. Really, really love our partnership.
Oh, we do too. Thank you so much. The day we found you is one of the best days. Next to my
Thank you
husband, it's one of the best days. Okay.
Have a great rest of the event. I will stay on for about another 15 minutes to answer questions in the Q&A if anyone has any.
That's super. Thank you.
Thank you.
Okay. And now we will hear from the world's #1 nephrologist, Dr. Nelson Leung from the Mayo Clinic in Rochester, Minnesota, who will tell us everything we want to know about kidneys, dialysis, kidney transplants, maintaining good and healthy kidneys. Take it away, Dr. Leung.
Thank you, Muriel. Muriel, by the way, you look great.
Oh, wow. Thank you. I'm wearing lipstick.
Ah, okay. Let me share my screen here.
And also they have a blur thing on my thing so I can, you know, make myself a few years younger.
All right. Are you seeing the presentation slides or do I need to switch?
You need to switch. I'm seeing 2 slides. I'm seeing kidney dialysis, the transplant, and then a little thing with circles on the right. There you
How
go.
about now?
That's good.
Okay. All right. So thank you, Muriel, for asking me to come and give this talk. Now, I know the audience, not all of you have AL amyloidosis, and as you can see, we know that there are now over 30 types of amyloid that affects human, and of those, over a dozen, the ones that are with an asterisk, will affect the kidneys. And so just a brief overview of how amyloid affects the kidneys. So this is a picture of a normal glomerulus. These are the filtering units in the kidneys. And the blood is filtered through here and then passes on to the tubules and eventually makes its way to the bladder to make urine. And on a healthy kidney, you see that the blood vessel walls are quite thin and fragile. They're quite delicate, but this is what an amyloid kidneys look like. So as the amyloid gets deposited in the kidney, you see that it ruins the structures and it closes the capillary loop. And these are just other pictures of amyloid in the kidneys. You've heard about Congo red. So this is a Congo red stain. And if we then polarize the light, we see that the Congo red turns to this green color, which we call apple green birefringence. And that's how we make the diagnosis of amyloid. So what does the, looking more closely with the scanning electron microscope, we can see what amyloid actually does to the filtering units of the kidney. So as you see, these little finger-like projections are on the blood vessel's wall. And what they do is they lace into each other. So like fingers, when you close your fingers against each other, they form this barrier which allows very small things to go through and water to go through, but larger things like protein and blood cells will not go through. But as you can see, when amyloid gets deposited, all these little finger-like projections develop these large, stumpy like shape. That's equivalent to having a colander, but then the holes getting a lot bigger. And when the holes get a lot bigger, what happens is that albumin, which is normally blocked from going into the urine, now can escape into the urine. And that's the protein that we find in the urine of amyloid patients. And this is where, some patients report having bubbles in the urine, and this is what it looks like. Now, there are other ways that the kidneys can also get injured, and this can happen in patients with AL amyloidosis, but certainly this is another way that patients with ATTR amyloid can experience kidney dysfunction, and that's what we call cardiorenal syndrome. So to make this really simple, as the heart function deteriorates, the amount of blood going to the kidneys decreases. Now, the kidney is all about blood. So what it does is that it releases chemicals to try to increase blood flow. And one of the things that it does is that it starts to hold back salt and water. Well, when it does that, the volume increases, but when the heart is already not pumping good, the increase in volume actually overloads the heart and make the heart pumps even less efficient, which makes less blood go into the kidney and the kidney acting even more. So it sets up this vicious cycle that both the heart and the kidneys get worse as a result of it. And then finally, the third thing that affects patients with amyloid in the kidneys are medications. So non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, amyloid kidneys are very, very sensitive to these medications. In addition, normally when patients have kidney disease and spill protein, nephrologists oftentimes will prescribe ACE inhibitors and angiotensin receptor blocker, ARB. But in amyloid kidneys, again, their kidneys are very sensitive to these medications, and these medications oftentimes will cause profound drop in blood pressure, which, again, remembering the cardiorenal syndrome cycle, that will make the cardiorenal syndrome cycle worse. And so neither nephrologist nor cardiologist use this very much in amyloid patients, or they shouldn't. There are antibiotics if patients are allergic to, can cause kidney dysfunction. And then even drugs like carfilzomib have a small chance that is used to treat AL amyloidosis sometimes has a small chance of causing kidney dysfunction. Now, can the damage in in the kidney from amyloid be reversed? Absolutely. This is a study that we looked at patients' kidney function after getting a stem cell transplant. Now, this study was done 20 years ago, and stem cell transplant was the state of the art at the time. But as you can see, over time, and this is over 4 years, 5 years, patients can actually have the amount of protein reverse and normalize, but it does take 4 to 5 years. Here is the mark at 1 year, and it's just around 50%. The chart on the right shows you that if a patient has reduction in proteinuria, that they're more likely, and these are the patients in black, they're more likely to have stable kidney function or improved kidney function, whereas patients who don't have reduction in proteinuria, they're more likely to have declining kidney function. We also see this in ATTR amyloidosis, that if patients get treated appropriately, this is patients that get treated with silencer RNA, they're more likely to preserve the kidney function, whereas patients that are treated with stabilizers are less likely, although this is a very small study and this observation definitely needs to be confirmed in clinical trials. Now, in AL amyloidosis, we have a staging system for the kidney. This is developed by Dr. Palladini, and the staging system consists of two parameters. One is how much protein is being spilled, greater than 5 grams is the cutoff, and also what is the level of kidney function. And that is eGFR of 50 or less. Now, patients with stage 1 will have neither of these. Patient stage 2 will have one of these parameters, and patient in stage 3 will have both of these, where the proteinuria is greater than 5 grams a day and the eGFR is less than 50. And with this, you can actually predict who is going to end up with kidney failure. Patients with stage 3 disease, nearly 60% of them will end up in kidney failure at 24 months, whereas patient in stage 1, nearly none of them develop kidney failure. Stage 2s are intermediate, where about 30% will develop it in 5 years. Now, Dr. Palladini also developed the response and progression criteria. Progression is defined by greater than 25% loss in kidney function. So it's either a 25% or more loss of the eGFR or a 25% rise in the serum creatinine. The response criteria is a 30% reduction in the protein in the urine without meeting progression criteria. And again, you can see that in patients that meet progression criteria, many more of them will develop kidney failure than those who do not. In patients that have a renal response, they are much less likely to progress to kidney failure with less than 10% versus over 40% of the patients who do not have a renal response. Now, more recently, Dr. Mukhtar, when he was working at the Mayo Clinic, observed this, that 30% reduction is actually the minimum, and it's oftentimes not enough to actually guarantee a good kidney outcome. In fact, what Dr. Mukhtar observed was that he was able to separate those who have a 60% or more reduction in the protein in the urine, and he called those very good partial response. And then complete response was normalization of the amount of protein in the urine. And what he saw was that as the response got deeper and deeper, the patient got better and better. And that can be seen in this graph, where patients who had no response in the top curve, many of them ended up in kidney failure, whereas patients with complete response had very little kidney failure. But what's more important is that what he found was that those who have a very good partial response in the orange were actually very close to those who had a complete response, whereas those who had a partial response, remember, those who have only 30% to 60% reduction of proteinuria, they actually behave more like those patients that did not respond. Now, there are patients that no matter what we do, they will not respond to therapy and will continue to lose their function. So this is a study out of the United Kingdom. And what they found was that in order for the kid, and these are patients in with the stage 3 disease. So these are the advanced patients, and these patients had an eGFR of less than 20. So they're very severe disease. What they found was in order for the kidney to be preserved, they have to have a deep hematologic response. What Dr. Dispenzieri talked about a very good partial response, and they defined that as having a DFLC of greater than 90%. For those of you who don't know what DFLC is the difference between the involved free light chain, so the bad free light chain, minus the uninvolved or the good free light chain. So we want a greater than 90% reduction, but that wasn't enough. What they found was that in these very advanced patients, if you don't reduce the DFLC by greater than 90% at 3 months, the patient still continue to decline and will end up losing their kidney function. So in these patients, a rapid hematologic response is very important to help preserve the kidney function. And Dr. Muhtar actually observed this. So once again, looking at these curves, you see that in patients with stage 1 or 2 disease, regardless of whether they had a very good partial response or a complete response, very few of them lost kidney function versus those who had no response. But if you look at the stage 3 patients, the graph on the right, you see that even those who had a very good partial response, over time, these patients continue to lose kidney function, whereas only those who had a complete response really were able to completely preserve their kidney function. So the staging system dictates what type of response you need in order to preserve the kidney function. Now, what happens if your kidneys fail as a result of, just being diagnosed too late and not being able to achieve the response? Well, let's look at what the kidneys do. The kidneys, we know that they remove waste products from our body, remove the excess water. They regulate the electrolytes, but they also regulate the pH of our blood. They regulate our blood pressure, and they help the bone marrow to make blood. Now, if we look at all of these functions, dialysis can take care of the waste product removal, the volume overload, the electrolyte abnormalities, and the acid buildup. However, it cannot regulate the hyperparathyroidism, which causes calcium to build up. And this requires drugs that are called calcium mimetics. Also, with the blood pressure, it can only partially regulate the blood pressure by fluid removal. So oftentimes when a patient develops kidney failure, they need blood pressure medications and oftentimes more than one. And then for the anemia, we need to give them drugs that stimulate the bone marrow to make blood, and these are called erythropoietin stimulating agents. Now, why do we do dialysis? Well, the advantage is that the availability. Dialysis can be performed almost anywhere, and nearly everyone can get dialysis. But the disadvantage, as we talked about, is that it doesn't replace all of the kidney function. And a lot of times the patient complain of fatigue despite having good dialysis run. So let's first go over what type of dialysis are available. So there are 2 types. The first type is called peritoneal dialysis. This was actually the type that was first made widely available. And what this does is that a fluid is infused into the abdominal cavity. It sits there for a while, it absorbs the toxin and excess fluid, and then it's drained out. Now, there are two types of peritoneal dialysis. The first type is called CAPD, and this one, the patient does this exchange several times a day. So the patient fills their abdominal cavity with the fluid. The fluid stays in there for several hours, and then it's drained. And this process takes about 30 minutes. But there's another type of CAPD called the cycler, where the fluid is placed on a machine, and the machine automatically infuses and drains the abdominal cavity over a time course of several hours. And this is typically done at night when the patient is sleeping. Both of these are done at home. The other form, which most people are more familiar with, is the hemodialysis. And this is one where a machine takes the blood out from the patient body, it cleans it through a filter right here, and it removes the waste products, it removes excess water, and it regulates the electrolytes, and then the blood is returned to the patient's body. There are also two types of hemodialysis. One is in-center hemodialysis, where the patient goes typically 3 times a week, and each run is about 3 to 4 hours. Then there's home dialysis, where the patient does this at home, and this can be done 4 to 6 times a week, and it's usually done for shorter periods, usually 2 to 3 hours. Home dialysis is much better because the more frequent you do dialysis, the better you can regulate the electrolytes and fluid status. However, not everyone can do this at home. The other form of renal replacement therapy, of course, is kidney transplantation. Kidney transplant takes a kidney from a donor, whether it's living or deceased, and then transplant it into the pelvis area of the recipient. So there are many advantages and some disadvantages. The advantages is that it does everything the native kidneys do, and it's definitely a better quality of life where you don't have to be on dialysis. The disadvantages are that it is not a cure. And what I mean by that is, if you have appendicitis and the surgeon takes out your diseased appendix, you're cured. You never have to go back to see the surgeon again. You don't have to take any medication. It's done. Kidney transplant is not that. You have to be on lifelong immunosuppression unless you have an identical twin. 2, there's always a risk of rejection. And if due to either rejection or infection, the graft can be lost. The other thing is that kidneys they don't grow on trees, and so there's limited availability, and it requires a specialized medical center in order to do a transplant. And not every patient is a candidate. Some patients are too weak; they can't endure the surgery, and they may not be a candidate. And finally, again, the immunosuppression has consequences. It makes the patient more prone to infection, and it also increases the risk of several types of cancer that can occur with the long-term immunosuppression. However, in those patients who are a candidate, we definitely encourage patients to undergo kidney transplantation. And there are some of you who might have been told that we cannot do a kidney transplant in patients with AL amyloidosis, and that is partially true. Some medical centers don't have the expertise to do these transplants, but at our center at Mayo Clinic, we have done over 100 patients with AL amyloidosis, and so we're very comfortable at doing AL amyloidosis patients. And in fact, in a multi-center trial that was done by the International Kidney and Monoclonal Gammopathy Research Group, we saw that patients who undergo transplant after they receive that if they achieved a very good partial hematologic response or CR, do quite well, as you can see by the red line. Now, those who have only a partial response or less, their kidney transplant don't do as well, as you can see here. And in a national study done in the US, we see that patients who have AL amyloidosis actually do as well as patients with diabetes. And so there's no reason for patients who are eligible for kidney transplant not to undergo a kidney transplantation. It's just you have to find the centers that have the expertise for doing these kidney transplantation. And with that, I will end. I would like to thank all my hematology colleagues in the Mad Dog group at Mayo, and also my onco-nephrology colleagues who helped me take care of these kidney patients. Thank you very much.
Thank you so much. There'll be lots of questions at the end of the program that we'll be asking, and we really I do want to mention, we so appreciate your giving us, all of you giving us your Saturday. And Dr. Liedtke and Dr. Dispenzieri and Dr. Leung have been giving us more than just their Saturday. They have traveled the country for us to do meetings in various cities, and we really appreciate it. So, we just want to say that our amyloidologists are the best in the world. Okay. And you are appreciated. I don't want you to think we take you for granted, even though we sometimes do. Okay. And now we're going to hear about financial aid from Paula Schmitt. So Paula, take it away.
Good afternoon, everybody. I have just put in chat several of the links that I'm going to discuss today. I also put up a link to our financial assistance chart, which Bob is going to post here on the screen in just a moment. There you go. Good news. We have good news today. I checked last night, and out of the 4 funds that we have, or 4 organizations now that have funds, that all but one of them are open. Healthwell Foundation, their cardiomyopathy fund. Whoops, if you can go back, Bob. Thank you. The cardiomyopathy fund, which is just about right there in the middle of the list, that one is currently closed. This is the first time I have seen this fund closed in at least the last 3 years that I've been watching that fund. So I was shocked when I saw that one last night was closed. But keep in mind that these funds, even though they're open today, they could close by noon tomorrow. They could close in a week. We never know when they're going to close. So when this funding is available, you need to jump on it as quickly as possible and get your applications in. Most of these you can apply online, or you can call them. The year is over more than halfway done right now. So a lot of you may have already met your out-of-pocket deductible for or hit your out-of-pocket maximum for your drugs so far this year. But just keep in mind that these funds, a lot of them will also either pay some co-pays, co-insurance, they'll pay deductibles. Some of them will cover premium costs for your insurance. So it just depends on which one of them you get in contact with and decide to pick out, their fund. Just know that each one of them is different. So look at them closely, if you have a specific thing you want to have covered. Healthwell Foundation will allow you to pay either for your co-pays, your drug co-pays at once, or your premiums. You cannot collect on both of those from Healthwell at the same time. So you have to pick one or the other. The way that I've always worked it, because my husband had one of these grants, was that if your copay, your out-of-pocket maximum for Medicare has been met for the year, or your copays have been met if you're on private insurance, you can switch. You can call Healthwell and say, okay, I want to switch to premium coverage. And you will then be reimbursed for the cost of your health premiums for the rest of the year, or Medicare Part B premiums if you're on Medicare. It's wonderful to be able to get that check every month. They send it to you like clockwork, and it's nice to have on hand. If you run across one of these and their fund is closed, they do have email wait lists that you can sign up for. And I strongly urge you to go ahead and sign up for them anyway. Even if you do get a grant now, go ahead and sign up for their wait list, because it will alert you when the funds reopen. If they've been closed and they reopen, you will get an email saying so. It may not be of use to you at that moment because you already have an active grant, but you may be able to tell a friend of yours that, hey, this grant just opened up, so give them a call. Now, we used to have 5 grants, 5 different organizations that were offering grants, but July 1, the Patient Access Network and the Patient Advocate Foundation merged together to create the largest private assistance fund out there. So that's why we only now have 4 on the list, where in the past we've had 5 on the list. Bob, if you could advance the slides by 2, please. Okay. When you are looking to see if you qualify for one of these grants, it's based on the size of your family and your income. Let's just say you have a family of 2, and most of these funds cover you at 500% of the federal poverty rate. So you would go to the 2 and then to the 500 column if you're in the contiguous United States. So you can make roughly $108,200 a year and qualify for assistance through one of these funds. If you live in a large metropolitan area, such as New York City, LA, where the cost of living is higher, you need to, if you're close to that threshold, call them up and find out if you are able to get a bit more, to have a little bit higher income and qualify. They do allow a difference for that in those high cost of living areas. So check on that if you're close to the threshold, because as you can see on the chart here, Hawaii and Alaska both have much higher rates as compared to the 48 states. But just, know these funds are out there and apply for them. They can be a big help to you. So don't let money sit out there and go wasted when, you can benefit from it. And that is pretty much it. Just know that it's there and apply.
Thank you so much, Paula. And remember, if you have any questions regarding financial aid, Paula at amyloidosissupport.org. She is our financial aid guru. Okay. And now if we can have our panelists all up there, we have some questions that have come in. Okay, Dr. Leung, Dr. Liedtke, Dr. Dispenzieri, super. Okay, Dr. Leung, this one was emailed in, and it's very interesting, and I thought I'd throw this out to you. Are you there?
Yeah.
We'll wait for Dr. Leung to return.
Oh, I'm here.
You're there. We don't see you.
My camera's been disabled by the host. You guys didn't want to see me.
Well, hey, wait a minute, Bob. He said I look good. Please, let's put him on there. Thank you. Okay. Tit for tat here. Thank you. Okay. Okay. Dr. Leung, this is from Ruth. There has been information rumbling on Facebook about using Ceylon cinnamon to improve renal failure. Is there any truth to this from the country of Ceylon?
But I'm not aware of that. And if there, right now, there's no drugs that we actually have that actually improve kidney function. We have drugs that preserve kidney function. And the only thing that we know that can actually improve kidney function is some experimental work with mesenchymal stem cells. But that's the only way that we know now that even has some potential, and this is in clinical trials. So If it does improve kidney function, it would be very little, and if you're near kidney failure, it would not do enough for you.
But as far as you know, cinnamon is not bad for the kidney. I mean, if I
No.
wanted to throw some extra cinnamon in something, it won't hurt me, will it?
Right, right.
Good. Okay. Okay, here's a question. Kappa light chains tripled in 6 months to 160. However, I'm lambda light chain that were 172 and now trending above 26. Should I be worried post-treatment 4 years? So this person is supposedly lambda involved, but their kappas are help me.
Yeah, I'm having difficulty too. I get, because then they say, and now trending above 26. So I'm a little, like it's all jumping. So number one, that ratio, we often will look at kappa to lambda ratio, and that ratio is pretty close to normal. So that doesn't look alarming, but those numbers do seem high. Again, we have to think about what units. So different labs sometimes report out in different units. So mgs per liter versus mgs per deciliter. So if this was mgs per liter, those numbers would still be on the high side. If the patient has some degree of renal failure, perhaps that would be why they're at that level. But without, I wish I'd love to answer their question, but I'm having a hard time really following what they're sharing.
Yeah, Lucinda, why don't you send me an email, Muriel@amyloidosissupport.org, and be specific and maybe include some more data, and then maybe we can get a more thorough answer for you. Okay, great. Okay, here is one from Patricia. On an elrantamab trial in Boston with immediate remission. Ooh, we love that. Any idea how long this treatment works for multiple myeloma? So obviously this person has AL and MM. We'll let Dr. Liedtke answer this. Also, when will the trial be available as a first-line treatment? Dr. Liedtke?
Yeah, those are great questions. I think the duration of remission it varies a lot according to the line of treatment. So if people have had a lot of different lines of therapy, then it may not be quite as long. And the elranatamab trial, at least the amyloid trial, I think only included 9 patients. So it's very difficult to kind of know exactly what to make out of data from 9 patients. But that's difficult to tell. In terms of when these drugs, CAR T or bispecifics, will be used for first line, I think we're making our way into the first line now for multiple myeloma, but I think that the same will eventually happen for amyloid as well. We just have to make sure that it's safe. There are some concerns, especially about patients who have advanced cardiac disease, about the safety of giving a drug that could cause CRS and potentially cause low blood pressure that then, like Dr. Leung said, can affect the kidneys. So, but over time, I'm almost certain that either CAR T or bispecifics or both will make it into the front line.
Are there clinical trials, Dr. Dispenzieri, for any of these drugs to be first-line therapies?
Yeah, actually, so we're going to have an ELRA study for first line and AL opening sometime, hopefully by the end of the year. We're doing it along with Cleveland. But a lot of the pharmaceutical companies are doing registration trials with the bispecifics and the CAR T, and they are actually targeting the as first line, which is great. But on another level, I'd love to see some more for relapse so that patients could go on those studies too. But a lot of their efforts are really going to be to try to compare it to Daracybord or whatever. I think it's easier to kind of get to an answer when you're dealing with first line patients because they're a little bit more homogeneous, even though they're still not homogeneous. But the relapse refractory, it's a little trickier, and then there's no standard second line therapy, and so. But yes, these things are definitely moving towards first line.
Anything you want to add to that, Dr. Liedtke?
No, I think it's very exciting for us to have those drugs available, and it's important that they're being studied in clinical trials. And I think for all of them, for bispecifics and for CAR T, there are trials being planned and started.
Okay, great. So there you go, Patricia. You got your answer there. Okay, Sally does, for the T1114, has anyone tested newly treated AL patients with venetoclax monotherapy? It's a starting line versus the Andromeda protocol. Is the DARA really necessary if someone has the T1114, knowing they have to eventually take venetoclax? So, and that's a good question. So, if they have the CD38 and they have the T1114, the Daricides is the standard of care, but the venetoclax seems to knock down the 1114. So is there a thought to make that a first line? We'll go with you, Dr. Liedtke, and then we'll go with you, Dr. Dispenzieri. Dr. Liedtke?
Yeah, it's definitely, so we know that patients, the 50% of patients with AL amyloidosis who have the T1114 respond really well to venetoclax. I don't know that we have any upfront data, but I think it's tempting to try it in the upfront setting. Daratumumab is such an effective therapy, and it's so well tolerated that I'm not sure that I would separate them. It'd be interesting to know what the single agent activity of it is in the front line, but you really want like a quick and deep response. So if I do give them, I usually give them in combination.
Yeah, we know a lot of patients that are on both the venetoclax and the daratumumab. Dr. Dispenzieri, your thoughts on that?
Yeah, there was a small study from China published a year or two ago where they did use venetoclax and dex as first line in T1114 patients, but it was only like 36 patients. But they did see a CR rate of about 37%, which seems lower than what you see with Daricides.
Yeah.
And so again, but very small, the VGPR better was 63 or 60% or so, but again, small numbers of patients, really hard to know. That doesn't answer the question about using venetoclax plus Dara up front and all that. I mean, I think there's a lot we have to learn about what's best, what's needed. Do you go with a combination, really just try to dig in deep and try to make things go away, and then hopefully you can have limited duration therapy. I think that is definitely a strategy. Obviously, the more drugs, the more immunosuppression, the more chance for side effects. So I think, first line for venetoclax is really a trial question and what to do in combination. We have very little clinical trial data on venetoclax in the AL space. A lot of it is really just retrospective, like Mayo did something, and Columbia, and you name it, and we all put our stuff together, or different groups in Germany. I mean, we put our stuff together. This is our experience, but that's not a true clinical trial. It does advance the knowledge. So I think we even need to know a little bit more in the relapse setting, or the refractory setting before, to me, that it would make sense, to do frontline, unless you want to replace I guess you could do replacing the Cytoxan and use venetoclax. There are all kinds of combinations you can imagine, but I think we need study.
I think that the insurance companies might have something to say about
True.
that too. So
Always.
always, right? Okay. Bonnie says, a second line discussion for treatment with MM and AL amyloid, autonomic neuropathy. Hang on, I lost Bonnie. She skipped somewhere. Okay, there we go. Affecting heart. What would be an ideal combo for second line, please? In New Zealand, and no dedicated amyloidosis specialist to ask. Oh, okay. So let's kind of give this a little extra whatever for Bonnie, because she's in New Zealand. Okay. So second line discussion, we assume that she had Daricides as the first line, and that didn't do as well as she had hoped. We're going to assume that, okay? So she's got all these issues, neuropathy, and she's got cardiac. So if she were your patient, we'll go with you, first, Dr. Dispenzieri. If she were your patient, what would be the second line that you would go for?
Right. So, again, when you're dealing with different countries, you have different limitations and restrictions and, what's available. So it's always a little more challenging. But if she, for example, she were in the US, I would really be looking at a bispecific or CAR T trial, or off late. Well, wait, she's 11. Is this one 1114, or that was the other one?
She
Hold on.
doesn't say. So we
Doesn't
don't
say.
know.
Yeah. So, okay, shouldn't say. So, the question whether venetoclax would be, but before even saying that, the big question is, okay, you have autonomic neuropathy, heart. How bad is it? How severe is it? Because that's going to color kind of what might be appropriate. If it's mild, then for sure I'd say let's go and see if we have a bispecific or CAR T. If she's translocation 1114 negative. If she has the translocation and or she's pretty frail related to her disease, you could use the venetoclax with a little bit of dexamethasone. Whether Dara would have a role if she just didn't do well with the Dara VCD, I'd probably just start with venetoclax, maybe a touch of dex, and then I could build from there. But that's only if she was translocation 1114. If those options aren't available, there's always the IMiDs, so medicines like Revlimid and pomalidomide. The problem with lenalidomide or Revlimid is that it can drop blood pressures. It can sometimes be a little bit toxic to the heart. So it's always that question, how sick is the person when you start? And then as you're starting any therapy, how do they tolerate it? Like, are they worse on it than off of it? Because we know that our medicines can make patients feel less good, and pomalidomide has less toxicity than the Revlimid, so it's in that same class of that IMiD class. But yeah, that kind of at this point, I mean, the other thing is if it's very mild cardiac and very mild autonomic neuropathy, you could even consider a transplant. But again, there's so many gaps in sort of knowing and personalization for any given patient.
Let me ask you, are you aware of any amyloidosis specialists? I know we used to have one in New Zealand, but he kind of moved to the US. So and what
Australia, but not, yeah, I don't, I don't know if anybody else here does.
Okay, Dr. Liedtke, do you have anything to add to what Dr. Dispenzieri said for Bonnie?
No, I totally agree. I mean, I think the other piece of information that would be helpful to have is when is the relapse happening? Is the relapse happening off therapy, and the Daracibody was 2 years ago? Then you could consider restarting, or was there never a good response in the first place, or is the patient on Dara only? Then you could build on that. So that would just be helpful information to have.
Okay, Dr. Leung, do you have something to add?
Yeah, so I know that the there's a Australian group of hematologists that has started a nationwide amyloid group, and I know that the New Zealand doctors can tap into that group. So what I would say is ask her doctor to look up the Australian amyloid registry group, and Dr. Peter Mollee, Mollee, is the head of that group, and have her doctor contact Dr. Mollee.
Speaking of registry, I forgot to have Bob talk about our registry. Remind me, we're going to give him a few minutes. Okay, coming up. Okay. OMG, I'm sorry. Okay. Oh, Ben, we know Ben. Hi, Ben. Okay, after T-cell treatment, I am on weekly IgG infusions for maybe 1 year. Is it the same for bispecific treatments? In other words, will that require him to have IgG infusions, Dr. Liedtke?
That's what we currently do. Yeah, we give it monthly, the IVIG infusions, but it's the same for CAR T and for bispecifics.
Okay. Same thing, Dr. Dispenzieri, no disagreement there?
Yeah, the one thing I'll throw is, we say CAR T is one and done, but because the patient has to go in for IVIG every month, in a way, it feels like it's not one and done, right? I mean, the active plasma cell directed therapy, but they have to get the infusion. Some people can do the sub-Q IVIG, which makes it more convenient, but most insurance doesn't pay for that. So for both of them, you're stuck going in.
Wonderful. Okay, Dr. Leung, what is the best type of pain reliever, fever reducer for a person with kidney amyloid to use?
Tylenol.
Tylenol.
So Tylenol can be used, but NSAIDs are absolutely out, and I don't really recommend patients taking any of the non-steroidal anti-inflammatory unless their protein is normal. So if their protein's normal, I would think that their kidneys have completely healed and normalized. But I've seen patients actually go into kidney failure with one dose of ibuprofen. So very
Ugh.
dangerous drugs in those patients that have they're spilling lots of protein. They can use aspirin. So if they need to be on an aspirin for whatever reason, for their heart, they can use aspirin. But after that, it's only prescription pain meds after that.
Gotcha. Okay. Okay. Catherine asked you, Dr. Leung, can you clarify the difference between renal amyloid stage 1, 2, and 3 and stage of chronic renal failure stage 1 through 5? Ooh, good question,
Oh,
right?
yeah. So the staging for renal amyloidosis is really to give us an idea of how severe the amyloid is in the kidney. And that's why Dr. Palladini has taken the two parameters, how much protein is being spilled and how much kidney function is left. And that gives us the staging as to how severe the kidney disease is with amyloid. But this system only is valid in patients with AL amyloidosis. It doesn't. In fact, people have been trying to come up with a staging system for AA amyloid, and it's going to be different. Now, the staging for chronic kidney disease is used to gauge how severe the kidney problem is in patients with generalized kidney diseases. So, if you have kidney disease from diabetes, kidney disease from high blood pressure, kidney disease from vasculitis, you can use every one of those patients can use the chronic kidney disease staging. And that's actually a very good question, because patients often get very nervous because they're told that they have chronic kidney disease stage 3, and they're like, oh my God, how did I skip 1 and 2 and not know it? And that's because we don't always consider 1 and 2 abnormal. Especially in older individuals, chronic kidney disease stage 1. In fact, a very prominent nephrologist who is in his 80s argue against being labeled having chronic kidney disease because his kidney function is a little bit lower. So as we age, our kidney function will drop. And by just conventional rules, we don't actually report out abnormality until the kidney function drops below 60, which is the cutoff for chronic kidney disease stage 3. And that's why patients don't get notified that they have abnormal kidney function until they drop below 60. Now, again, if you are in your 20s and you have a kidney function of 55, that's very abnormal. But if you're in your 70s or 80s, kidney function of 55 may not be that abnormal. So again, it's just a way for nephrologists to really gauge how much kidney damage or kidney injury there is. But the other thing about the chronic kidney disease staging is it only really tells us what the kidney function is. It doesn't actually tell us that there is damage to the kidney. So you have to take that with a grain of salt, and it's really just a way to tell us where a patient is with their kidney function.
Great. Thank you. Thank you so much, Catherine, for asking that question, because I think we all needed to hear that for sure. Oh, Edith, I know look at all the old friends we have piling up here. This is great. Hi, Edith. What center is studying DARA as a maintenance drug? I guess, how long you have to be on it versus what the Andromeda trial said, I guess, is what that question would refer to.
I mean, we are studying it. We have a clinical trial just kind of looking at, after typical 6 cycles of the Daracibor-D and then randomizing patients to, commit to the full extra 18 months, so to speak, versus if they get in a deep response, really shortening that duration of treatment. I suspect others are doing it, and I think people are sort of sometimes doing it not on clinical trial and will report what their results are and kind of compare it to what was seen with Andromeda. And there may be others as well that I don't know of.
Dr. Liedtke, are you doing anything like that?
We're not studying it, and you're studying it in a prospective trial, right, Angela? Yeah. We're not doing a prospective trial. I've actually been thinking about doing just a retrospective analysis to see, patients who, let's say, have stayed on it for 2 years versus some of our patients actually stay on it longer. The problem with that is that there's always some kind of bias. There may be a reason why somebody decides they want to stay on it longer. And so in that sense, a randomized prospective trial is always going to give you the best data.
Thank you. Okay, Pamela. Oh, I knew Pamela too. Can you get CAR T after a kidney transplant, Dr. Leung? Everybody?
So, yes, you can, but it's very difficult. So, the quick answer is yes. It has been done. There's about a dozen case reports in the literature, but I'll tell you the issues. The issue is that, as I mentioned before, after a kidney transplant, you need to be on immunosuppressant to prevent rejection. Well, the immunosuppressant that we use targets B cells and T cells, which is the cells used in CAR T. So the immunosuppressant renders the CAR T cells less effective if you have to use them. But if you don't use them, you end up with rejection. So that's the problem that people have faced when trying to perform CAR T cells in patients with solid organ transplant, is that you have to really balance making sure the T cells are healthy and effective versus the rejection rate. So I don't want to say no, but realistically, there are very few centers that have the expertise to do this. I mean, I'm sure Dr. Leidtke in Stanford can. We have done a few. There have been a few in the East Coast. But finding that balance is very, very important. And I think that, in fact, I just gave a talk on this the other day, and someone asked the same question. I think it really has to be done on a case-to-case basis. You really have to evaluate the immunology of that patient and see how well they can tolerate coming off immunosuppression, and also, how comfortable the center is. And you have to go, this is one of those cases where you need a very, very specialized center. Not only can they do CAR T, but they have to have a transplant center there where the CAR T doctor can talk to the transplant doctor to really fine tune that immunosuppression.
Wow, that's quite complicated. Anything to add to that? Oh, wonderful doctors? No? Okay. Okay, here's Ben again. Can you share if you have taken amyloidosis patients through cytocell therapy and if they experienced any neurological issues and if they have stayed in remission? Dr. Dispenzieri?
Yeah, we have, and there are a number that have done very well. The toxicity is less than what we would expect. I did unfortunately have one patient who was in his early 70s who did experience the neurotoxicity, not the acute neurotoxicity, but delayed neurotoxicity, and had like a Parkinsonianism type of issue. And he had the inflammatory or immune enterocolitis, and he really did not do well. He had a hematologic response, but that's the issue with the cilta-cel. It's highly effective, and you can get really durable responses in the myeloma space, in myeloma patients where obviously many, many more patients have been treated. We're seeing these delayed toxicities in somewhere 4 to 8% of patients that are just really things that stick with a person, and you kind of have buyer's remorse that you ever did it. The vast majority don't have these, severe delayed toxicities, but the numbers in the AL space, whether it'll be different or whatever, is yet to be known. So I think some of these other new CAR Ts are going to be really interesting to study, and they're even in the myeloma space. There are other CAR Ts coming up that may have less neurotoxicity as well. But time will tell when something's new. It always looks like a shiny new penny, and then you kind of see its flaws or some of the limitations and some of the potential issues as time goes on. So.
Dr. Liedtke, anything to add?
Yeah, same at Stanford. We have a few, and luckily they've been doing well. One thing that I think may work in favor of the amyloid patients is that the disease burden is not so high. So generally they tend to do well, but I completely agree with Dr. Dispenzieri. I think we either put patients on a trial if there's a trial available, or otherwise just wait for some of those other newer CAR T versions that have less or none of the delayed neurotoxicity.
Okay. Catherine asked another question. Can someone give a brief rundown of the FDA approval process for, I think did she want to say emerging treatments?
I think she wants a Tanamic, maybe.
Oh, okay.
I don't know. I'm not sure.
Let's leave that. And you know what? I'll ask her to send me an email clarifying it, and then I'll send it to you for an answer. Okay. Karen says, I just listened to a webinar with a nephrologist, just a nephrologist, obviously not you, Dr. Leung, right? A nephrologist, that stated to use ARBs. And Dr. Leung, you stated these drugs are not suggested for AMI patients. Can you clarify, or is there some medical disagreement? You're on.
So ACE, as I said before, ACE inhibitor and ARB are used in a lot of kidney diseases, especially for those kidney diseases that spill protein. However, actually all amyloid nephrologists and amyloid cardiologists know that patients with especially AL amyloidosis don't tend to tolerate ACE inhibitor and ARB very well. In fact, I've always joked that I've taken more people off ACE inhibitor and ARB than I put them on. Now, does that mean that you can't put them on an ACE inhibitor and ARB? No. So if they have high blood pressure, I do put them on it at times. But I don't put them on when their blood pressure is normal or low, just so we can try to reduce their protein, because I've had many patients faint. I've had patients ended up in the ICU because someone thought it would be a good idea to put them on an ACE inhibitor. And so if you ask me, routinely, no. But if they have high blood pressure, then ACE inhibitor and ARB can be used cautiously.
Okay, cautiously, we got that. Okay, let's see. Let's see. Pamela, okay, you got a fan there. Okay. How do you choose between CAR T and bispecific? Okay, Dr. Dispenzieri. You've got the one and done versus the one and
So
not done.
mean.
So
That is such a hard question. I was hoping you were going to ask Dr. Liedtke that one first. It's a really hard decision, I think. There are a lot of things that go into it, but even in myeloma patients, it's a challenge because they each have their pros and cons. Especially in amyloid, we're still learning so much. And so I'd say, I would lean towards the trial. If you have a trial in one, I do that. And if you have the trial in the other, I do that. There's some really interesting data. Again, we borrow from the cousin multiple myeloma because we know more and they're both killing plasma cell, they're both plasma cell disorders, but there's like combinations using like teclistamab and daratumumab, which is a bispecific in Dara, and that in myeloma, which is way more aggressive, that looks like it performs as well as the CAR T does. We know that, for example, daratumumab, which isn't a bispecific, but just an antibody, works so much better in AL patients than it does in myeloma patients. We've observed that the bispecifics work so much better in AL patients than it does in myeloma patients because of the low tumor burden that they have or the lower plasma cell numbers. And so, I'm thinking if it's a choice between cilta-cel and a bispecific, I'd probably, which is the cilta-cel is the CAR T, and a bispecific, if it's like off study and that's all, I would go with the bispecific because I think that if the patient doesn't have a lot of myeloma features, I think that we can get away with a lot less therapy and have really good results. But it's, I think, it's an excellent question, but I don't think we have a perfect answer to it. I'll stop there.
Dr. Liedtke, let's have your 2 cents on that one.
Yeah, no, I totally agree. I mean, it's a really difficult question, and it oftentimes is a very personal question. So what we generally do is just, go over the logistics, the side effect profile of both therapies, and then a lot of times patients will decide, some patients don't have enough family support to stay with somebody during the CAR T, and it's just easier to do the bispecific, and others really like the one and done idea, even though they still need to get IVIG every 4 weeks, but that just really appeals to them. So a lot of times I think it's almost like a personal decision that the patient makes. There's a little bit of data from the myeloma literature that if you're considering that you might actually use both at some point, that it's better to start with the CAR and give the bispecific later than the other way around. So we discussed that as well. But not everything is the best for every individual patient. So I think we just discuss a lot and discuss the data and review it and have the patient discuss it with their families and then come back to us and decide. And both are really fantastic options. So in a way, you can't go wrong.
Let me be the devil's advocate here and ask you both. Okay, if not on a clinical trial, which one does insurance give you the most problems with, the bispecific or the CAR T? Dr. Dispenzieri?
So currently the bispecifics, there's no FDA approval as second line therapy as a single agent. And so, but there is FDA approval for using a CAR T as second line. So as just to use a CAR T is easier in terms of insurance in the AL space today, that'll change. If you really want to go kind of crazy in a very healthy amyloid patient, and they have myeloma-like features, using the data from the Majestic 3 trial, which would be Dara and teclistamab, is reasonable because that you can use as, like the next second line therapy. So probably the short answer is if it's not on study, CAR T is probably easier to get access to if it's the second line.
Dr. Liedtke, what do you have to say?
I agree. I think, second line for bispecifics, you have to combine it with Dara. So if you want to give it second line, then you have to give Dara and teclistamab. And otherwise you can give CAR T, or you can apply get insurance approval for second line CAR T. We've not had a lot of problems getting it approved. So that question alone, I think, is not oftentimes the tiebreaker or the decision maker.
That's great to hear. Okay. Before we go on, because what Bob has to tell you about our registry that we've been working on for several years, and it'll just be a few minutes. So, Bob, are you ready to tell everyone about the registry, and then we'll go back to the Q&A?
Sure, we can do that. So let me go and share a screen, and if everybody else just mutes for a moment. So we've got just me talking. I won't go on camera, but I'll talk through this. So thank you all. Here we are. We're listening to some of the premier doctors nationally and internationally talk about AL amyloidosis. They're giving their time on a Saturday, which is great. But similarly, we're going to ask all of you who are watching this today and anyone else who's got AL amyloidosis or any type of amyloidosis in the United States to participate in the amyloidosis patient registry, which we are happy to say is going to be launching this October. Very exciting. So the registry, it's kind of basically it's a fancy name for filling out surveys online that will tell us about how you are doing and living with amyloidosis. We are partnered with the National Organization of Rare Disorders, that's NORD. They have a platform called I Am Rare. It's an online platform. And we are going to be asking you to register and give your consent for this. Consent will cover both legal issues as well as privacy issues and others, so that you know what we're asking of you. But then we're going to ask you to tell us about how you're doing with amyloidosis. We're going to ask who you are and the demographics. We're going to try and capture the journey that you've gone through, both from the diagnosis and through the symptoms that you've suffered. How you're feeling about it, that's the health and well-being portion about this, and that reflects sort of day-to-day living. The treatments that you've gone through or are currently receiving, and then what the impact is about the quality of life that you're having with amyloidosis. And through this, we're going to try and compile a patient-focused data set that researchers can use for multiple purposes, but not the least of which is helping get a better description about what the patient voice is with amyloidosis. But we talked about quality of life, but how you are proceeding under these new and very exciting treatments that are coming out. We've talked about obviously bispecifics and CAR T, and what the future might be with depleters as well. We're trying to capture all this. It will also be an opportunity to maybe get upfront on clinical trials, to look at different research projects that might be going on where researchers would want a particular type of patient. So we're going to be managing that by any IRB or international or institutional review board. So a board that's set up to make sure that we're following all the rules and regulations regarding the patients. Any approved study would go to our board, and we have board members who come from Mayo. Dr. Leung, for example, is a member of our board on this. Our board will give approval for a research study, and then the researchers will be able to access anonymous data from the registry and try and select participants in the registry that they would like to further examine. And then through that process, you will be able to decide whether or not to participate in a research project. So through that, we hope to provide a real resource for the entire amyloidosis community, a resource that's not beholden to a particular pharmaceutical company or that's not focused at a specific center of excellence, but is really broadly available to the amyloidosis research groups. And the big thing that this is going to do for us, as we always say, you're not alone. Well, this is going to amplify the patient voice. So you know you're not alone. You're here on this webinar. You're listening to Muriel and the experts that we have on here. You know you're not alone, but this is going to compound that. So what can you do? When we launch this, you will see it through emails and other ways for us to communicate with you. We would like you to sign up and add your data. Give of your time, just like our doctors are doing today. We would like the physicians and the medical centers of excellence for amyloidosis, to also inform and promote the registry and participation within the registry. And our sister organizations as well, we're going to have them spread the word. It will take a little bit of time for us to gather this data to a sufficient level that researchers will want to access and use it. But the greater that we have the participation coming from the amyloidosis community, the better that this will be to serve us all. So with that, look for more information coming, both before October and in October. Sign up and let's make this a big success. Thank you.
Thank you so much. This is very exciting. Long time coming. So, and they'll be able to fill clinical trials this way, at least be aware of clinical trials that they might want to join in on. It's so exciting. It really is. Okay, next question. I seem to be more susceptible. This is Freda. I seem to be more susceptible to UTIs since diagnosed with AL amyloidosis. Is this normal? Anybody?
Is she on any treatment? Then yes, the treatments suppress the immune system, so it's not uncommon to be more prone to infections.
Okay. Let's see. My transplant was 1.5 years ago. I've been in complete response for 5 years. My Prospera test went from 0.8 to 9.9 after renal biopsy and CT scan. My kidney graft is not in rejection, is healthy, and CT scan was clear. What else could be causing this very high number confirmed with the second test? Did change from sirolimus back to tacrolimus and next Prosper's test on 8/24. This is beyond my, Dr. Leung, this is all about you.
So let me see. I'm not sure. I didn't catch which number was high.
Prospera. I've never heard of a Prospera test.
You know
We
what?
don't use that test here. I think that so that's a test that we don't use that here, but that's a test that is used to detect rejection. And it actually it's not specific for rejection. It's more a test of kidney injury, which in kidney transplant patients is more likely to be from rejection. So it's kind of a rejection, but it's really a kidney injury test. So I don't know what the biopsy showed, so I don't know what may be causing some injury, but it's good that it's not rejection. But certainly tacrolimus can injure the kidney. And one thing that is done is that they can switch to sirolimus, but sirolimus is not completely free of kidney injury as well. In fact, one of my colleagues was one of the first people to report toxicity in the kidney with sirolimus. There is another immunosuppression that can be used that is much less likely to cause kidney injury. However, that particular immunosuppression cannot be used in patients that have certain viruses. So it's something that, I think that this question, we can give a general answer to, but I can't give a specific answer just because I don't know what the biopsy actually showed, and I don't know what her viral status is, and I can't make that recommendation to see if she would qualify for the other immunosuppression drug, something that she needs to talk to her transplant nephrologist about.
Thank you. Okay, we've only got a few more minutes. Well, actually, we're over time now. We appreciate it. But here's an interesting question. I do want to get it in. And then everyone else that we didn't answer your question, I want you to know that we will send them all to the doctors, okay? And we promise that they'll write them down or else they'll have hell to pay. What can I say, right? Okay, there was a question here that was about the anselamimab. Okay, since we know that it worked on the kappa and didn't work on the lambda, and thanks to that new exciting stuff Dr. Liedtke shared with us, we know that there's going to be a trial for the lambda. But meanwhile, will they be going for FDA approval on the on the kappa effective drug, or what's the story on that, Dr. Liedtke?
Yeah, I'm sure that, there have been discussions with the FDA. We'll have to wait and see what they decide. But the data for the kappa subtype is, at least in my opinion, very, very convincing. But obviously, the FDA does their own analysis, and they will let us know.
Okay, well, we want to thank, we don't want to take advantage of you too much, and we are over time here. And like I say, everyone, we will get those questions answered, I promise. Okay. Thank you so much, doctors, for giving us your day. We will let you go back to your families, any birthday parties you might be having for grandchildren or children or whatever. And we want to thank everyone. And remember the survey. Okay, please fill it out. And if you need us, I'm Muriel at amyloidosissupport.org. You can call us daytime, please, at our toll-free number. Thank you, everyone. Thank you, Bob and Paula. And thank you, Monica. And goodbye, everybody.
Bye. Thank you.